My name is Whitney Breakville, and I'm doing a paper or a speech over before, during, and after carotid endarterectomy. Many people nowadays undergo a medical procedure called a carotid endarterectomy, or CEA for short, to treat carotid artery disease. A carotid endarterectomy is a clean case involving the removal of plaque from the walls of the carotid artery through an open incision in the artery. This disease causes few symptoms, although there are tests that can detect narrowing of the carotid arteries, such as an ultrasound of the neck. This procedure, usually done on older people whose plaque has built up over the years, helps to achieve proper blood flow through the artery to the brain to help prevent transient ischemic attacks or a major stroke. Even with diagnostic testing, it is a preventative measure. The first sign of having a carotid artery disease is stroke or ischemic attack. Fragments of plaque or blood clots migrating can cause these transient ischemic attacks or complete blockage of the larger carotid artery branches, resulting in a stroke. Although most patients are older, this problem can affect anyone, so it is not limited to older people. If a patient has a complete blockage of the carotid artery, a carotid endarterectomy is usually not performed because the risk of fragments migrating is too high. Today I'm going to talk to you about the procedure so that you can understand its risks and its rewards. I'll begin by going over the planning stages, then I'll take you through the prep process. Finally, I'll take you through the procedure step by step from the first incision to the last suture. The surgeon must plan the procedure accordingly, since there are other possible procedures that might need to be done before or after the CEA. If the patient has stenotic cerebral arteries, they will require an endovascular stent inserted percutaneously via femoral artery puncture under fluoroscopic guidance to avoid the surgery. For many years, CEA with angioplasty was thought to be the best treatment for stenotic cerebral arteries, but the use of the endovascular stent has become the more beneficial procedure for the patient. Over the past decade, carotid stenting has been used as a less invasive method for treating patients with significant carotid artery stenosis. Restenosis, or the abnormal narrowing of the artery reoccurring after surgery, can occur from radiation therapy. To treat restenosis, a synthetic patch graft is applied and fixed with fine vascular non-absorbent suture during CEA to ensure the artery won't narrow again. There is always risk for stroke, heart attack, or facial paralysis during or after surgery, but if the proper precautions are taken, it is much less likely. To prep the patient for CEA, a forced air warming blanket may be requested. Central venous pressure, arterial or venous pressure lines, and electrodes are placed on the patient for continuous EEG monitoring of brain activity, while cardiac function is monitored by the transesophageal echocardiography. If an autograft isn't going to be taken, disposable leg wraps are placed over an anti-embolic hose, and a decompression device is used to ensure proper circulation through the legs during surgery. Either general anesthesia or regional anesthesia, which is just a local block, may be used. When using a regional anesthesia, the patient will respond to simple neurological tests, such as speaking or hand strength tests. Prior to surgery, the surgeon might recommend the patient continue the use of aspirin to help keep the blood thin, and right before surgery might administer heparin for the same purpose to prevent clotting. The patient is placed in supine position with their neck extended with a towel roll underneath their shoulders to help hyperextend their neck. The patient's head is turned away from the affected side in a donut headrest with the minimal movement, and the arms may be extended upon padded arm boards with a pillow placed under the knees, or any other area where pressure might be applied to the body. Skin prep is applied to the neck and extended from just above the infraocular border to just below the axillary line, and then down the table at the sides. Towel and lap sponges are placed around the sides of the neck to prevent pulling, and a cotton ball is placed in the ear to prevent prep from entering the ear canal. Draping for a carotid endarterectomy is like that of a thyroidectomy. The surgical site is draped with towels, and they are secured with towel clamps or skin staples, followed by a clear incised drape to cover the towels. A split sheet is draped over the patient to surround the head and exclude the face. If a patch graft is needed from the patient, skin prep is applied to both legs. Synthetic patch graft requires a folded towel with a small fenestrated drape, but if the graft is from a patient, more towels and drapes are required on the legs for removal of the graft. Prior to the first incision, the instruments on the Mayo stand and back table must be kept neat and organized to ensure maximum efficiency during the procedure. To begin a CEA, an open incision is made along the anterior border of the sternomastoid muscle. Vascular forceps, Metzenbaum scissors, an ESU or Bovie, and sponge dissectors are used to carry the incision deeper until the carotid artery sheath is located. A variety of retractors such as a dull Wheatlander, Army Navy, and dull rakes should be readily available for the scrub tech to provide to the surgeon. Metzenbaum scissors and fine tissue forceps are used to mobilize the common, external, and internal carotid arteries, and extreme care is taken to prevent damage or injury to cranial nerves 10, 11, and 12. Vascular clamps and vessel loops are used for close and distant control of the carotid artery and where it branches off, which is not fully mobilized. Small hemostats or mosquitoes are used to clamp the ends of the vessel loops. At this time, the anesthesiologist will administer the heparin mentioned before to help prevent clotting and reduce the risk of emboli. The carotid sinus may be injected with 1% lidocaine to prevent slow heart rate and low blood pressure associated with manipulation of the carotid body. The number 11 blade followed by the pot scissors are used to make arteriotomy. A pen-filled elevator, freer elevator, wide tip atraumatic suction, and straight hemostats should be available for the immediate use in case the surgeon needs them. The surgeon will indicate the preferred vascular clamps that they will want and will clamp the internal, common, and external carotid arteries and notify the anesthesiologist and circulator, who will keep record of the length of time the arteries are clamped. If a shunt is used, such as a Javid shunt, it needs to be placed to ensure continuous blood flow to the cerebrum while the thick yellow rubbery plaque is being removed. It is passed proximal and distal to the arteriotomy and secured using a Javid clamp and a Rummel tourniquet. The shunt will be flushed with heparinized saline prior to passing it to the surgeon to make sure it is thoroughly clean. The cross clamps can be removed once the shunt is in place. Blunt dissection is often used to free the plaque from the artery wall, but the use of vascular forceps or a straight hemostat to gently lift the plaque from the intima is another approach. Making sure all plaque is removed to prevent emboli. Pen-filled and freer elevators, whichever the surgeon prefers, are used to create a dissection plane between the plaque and the lumen wall. The plaque removed is often collected in a basin on the field by the scrub tech. The surgeon then applies a bypass graft patch from the common carotid artery to the internal carotid artery using size 6/0 or 7/0 interrupted polypropylene sutures. If an intimal flap develops, fine sutures are used to tack the vessel wall, eliminating the need for dissection when blood flow is restored. The lumen is flushed with heparinized saline before closing the arteriotomy. If the lumen appears stenotic after flushing, a synthetic patch graft is used. If a shunt used before final closure, the shunt is removed and flushed again to remove any bubbles and debris before assuring hemostasis, and the arterial clamps are sequentially removed. Topical hemostatic agents such as gel foam or Surgicel should be available to help control leaks if any are noticed by the surgeon or any other sterile team members. The suture line is then observed for leaks, and the blood flow is confirmed with Doppler. Doppler intravascular ultrasound or C-arm fluoroscopy may be used to check the patency of the vessel above or superior to the surgical site. The wound is then closed in layers using 3/0 synthetic suture for the deep layers with a Castroviejo needle driver and 4/0 nylon suture for the skin, and a drain may be used to contain any residual drainage after the procedure. Finally, the wound is covered with a gauze dressing, and the patient is taken to the neurosurgical ICU for monitoring because the risk of hemorrhage, neurological deficit, and respiratory complications may occur. Now that you understand all the aspects of the procedure and the risks and rewards that go with having a CEA, you'll be better prepared to determine if it is what is right for you or a loved one. And with the advancements in medical technology, this procedure will only become safer and more efficient as an option for people in the future. Thank you.